I'm Peggy Peck, MedPage Today, and I'm here at the American Stroke Association International Stroke Conference in San Diego. The news here today was time and timely, quick treatment of stroke. I'm here to discuss that with Dr. Jeffrey Saver from the University of California, Los Angeles, and from Dr. Krya Becker from Washington University in Seattle. So let's start with you, Dr. Saver. You had an interesting study where you addressed the so-called golden hour. We know that time is always important. Time is brain, as they say. Why don't you tell us about these more recent findings?
Sure. Well, we know that we have to treat patients quickly with the only proven drug for treatment of acute ischemic stroke, TPA. We have a 3-hour window on the label, but the earlier we treat, the better. Every minute that happens without treatment, 2 million nerve cells die. Every 10 minutes that go by without treatment, 1 fewer patients will benefit from treatment. So we looked at the national registry, the Get With the Guidelines Stroke Registry, to which over 900 US hospitals have now contributed about 550,000 patients at the time of this analysis, looking at the patients who did their bit. They got to the hospital in the first 60 minutes after onset in that golden hour. And there were over 30,000 golden hour patients in the US at these 900 hospitals over the 5 years of the study between 2003 and 2007. And it turned out that if you got to the hospital right away, you got treated with IV TPA more frequently. Twice as often, 27% of golden hour patients received TPA, 12% of 2 to 3 hour arriving patients. So the first message is that many patients have learned that stroke is a treatable neuroemergency and are activating the EMS system, getting to the hospital quickly. That's good. Many other patients are still not getting to the hospital early enough, and we need primary care physicians, family practitioners, and everyone to educate any patient over the age of 40 in what the stroke warning signs are and the need to activate 911 if you're having stroke warning signs.
Well, let's talk though a little bit about the door to needle issue, because as you said, in many of these patients actually they were doing their job. They got there very quickly in less than an hour. But then they come into the hospital, and you looked at, I believe it was a median treatment time of 90 minutes. Was that correct? Door to needle? For the
golden hour arriving patients, yes. You know, there's a national stretch target that the door to needle time for giving TPA in stroke patients should be 60 minutes. The door to needle time for lytics in heart patients is 30 minutes, but stroke patients are more complicated. You need to do a CT or MRI scan, do the neurologic exam. So the recommendations are to try to get the drug started within 60 minutes of arrival. And we found that the average time of all patients treated was about 85 minutes, and it was longer in the patients who arrived early after onset. Likely the treating physicians felt they could take a little more time, understand a little better about what's going on, and so the average door to needle time in the golden hour arriving patients was 90 minutes. Only 18%, fewer than 1 in 5 patients, was treated within the target of a door to needle time of 60 minutes. That gives us a new educational target for emergency physicians, neurologists, stroke team physicians, and practitioners everywhere, that when a patient's done their bit and has gotten to the hospital early, then it's our responsibility to do our bit and have our hospital systems in place to get the drug safely and rapidly to that patient.
So even if they arrive early, you shouldn't consider that you have more time to deliberate and maybe slow it down. Always have to move quickly.
That's absolutely right. What's the time window in an acute stroke patient? Some people say 3 hours. That's incorrect. The time window in any acute stroke patient before more nerve cells die is 1 minute. In the next 60 seconds, another 2 million nerve cells will die. So you have to treat every patient quickly.
So now you're talking about a therapy, TPA, that as you say, and you have said repeatedly, is a proven therapy. Dr. Becker, you've been discussing at this meeting therapies that are approved but not proven. Is that correct?
That's correct. The classic example of an approved therapy that's not proven is endovascular clot retrieval in the treatment of ischemic stroke. So the FDA has approved the devices to revascularize patients who are experiencing a stroke without any proof that that therapy actually improves stroke outcome. The other example would be drugs or procedures that are available, approved for other indications, but not proven in stroke. And so another example of that would be recombinant factor 7A, which is approved for the treatment of patients with bleeding complications and hemophilia. But it has been studied in using it for treatment of hemorrhagic stroke to stop bleeding. Studies have not shown it to be effective. The drug is available. And so the question is, do we use these therapies that are available but haven't been proven to improve stroke outcome?
Mm-hmm. Well, let's talk a little bit first of all about the device, because in the case of the ICH treatment, that's actually an off-label indication. But if we look at the device, the Aspirate, the Mercy device is one of them, I know, and Penumbra, is that the
That's
other
correct,
one?
yeah.
So if we look at those are approved, but they're approved without data to show a survival benefit. Isn't that correct?
That's correct. So the FDA approved these devices in a prospective, non-randomized study, and the approval was based on being able to show that they were able to recanalize blood vessels in patients experiencing stroke.
Right.
And the outcome data really is difficult to put into perspective without a control arm of the study.
Now, I know that you were involved in one of the programs with a debate, and you took the con. So tell us a little bit about why you took that position in the debate.
The reason I've taken this position is not because I'm a therapeutic nihilist, but because I like to see good clinical science done. I think, we're in tough economic times, and I think that these very expensive therapies that also carry real risk to our patients need to have demonstrated benefit before we put our patients at those risks. The other thing is that the historical controls that have been used as comparators are now a decade or more old. And there's been a lot of systematic changes in the delivery of healthcare over the last decade or so, such that if you look at clinical trials, even the placebo-treated patients are actually having improved outcomes. And so it's hard to know when you're comparing a therapy now to a control arm of a study done 13 years ago, what that really means.
So, do you think, this is an issue that comes up sometimes in the field of cancer, where you have a treatment that is an approved, but not for that indication, and people are using drugs, they like to mix them all the time, that by doing so, that might decrease the use of an approved therapy? In other words, is there a danger that people will go for, those aspiration devices, they're really kind of gee whiz science, and they were presented that way, made a lot of headlines when they were approved. So is there that danger that people will think that, and I wonder if this is like a patient demand, patient-driven danger type of thing?
I'll certainly give you my own personal experience with that, and I'd love to hear Dr. Saver's experience. But certainly in our community, there are many institutions where patients will be taken directly to the angiography suite and receive an endovascular procedure, even if they're in the 3-hour time window when they could have received IV TPA, which has clearly been proven to improve outcome. So that certainly is a danger. And then the other issue that I think you're kind of hinting at is, when you want to do a randomized controlled trial to show efficacy, if a patient's able to get the therapy outside of the clinical trial setting, they often refuse to be randomized. So it's actually difficult to get the data to show that the procedure really works.
Mm-hmm. Dr. Saver, would you like to comment on this, on that?
Absolutely. I fully agree that it's not at all desirable to have patients forgo a proven therapy of marked benefit. TPA for every 100 patients treated improves the outcome of 32 and harms 3. It's a markedly favorable benefit to harm ratio. In order to get a device therapy that is of unknown benefit, it's a little bit of a less stark issue for us, because many patients are being treated with bridging therapy. They get IV TPA on label on their way to the cath lab, and then get the device if the TPA didn't work. So it's not so much an either or, and when it is, then it's really a major problem. But the clinical trial issue that Dr. Becker brings up is a critical one, that the premature approval of these new category of devices has made it very hard for us to be able to scientifically study them and learn the best way to use them in patients.
So sort of a rush to judgment in one sense on that. Well, I want to thank you both, Dr. Becker and Dr. Saver. Very interesting discussion and a timely one too, if I might say. little play on words there. So, and tomorrow we'll be moving on to more discussion, more news, more research here at the American Stroke Association International Stroke Conference in San Diego. I'm Peggy Peck, MedPage Today.